Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everybody. Thank you, Scientific Committee, for invitation. Thank you, Dr. Rafet, for nice introduction. My talk today will be focused on AML in 26, mainly the integration of menin inhibitors in therapy of AML. As you know, the risk of relapse and overall survival in AML patient improved over the last 3 and 4 decades. This data shown from SWAG Cancer Network improving the relapse rate over the last 3 decades until 2010 and reflected in overall survival, mainly due to intensification of the chemotherapy and good supportive care. And the majority of the patients in this graph was receiving the intensive chemotherapy 7+3 as an induction for AML therapy. Also, as you know, the low CR rate, it's correlated with the poor outcome and poor overall survival, especially if we have treatment-related AML. If they have CR rate around 61, it's reflecting in poor overall survival. As you know, the ALN risk stratification in 2022 was updated with some of the main changes, mainly the NPM1 now considered to be adverse risk factor if they are associated with the poor or adverse cytogenetics. Since 2017, we have the KMT2A as adverse risk factor. Also, it's done multiple study for validation of this ALN risk stratification, which showing the 3 category with reflected in the overall survival. But to consider this risk stratification was done in intensive chemotherapy patient. MRD analysis post-induction was not included, which might change the risk stratification post the induction. This is the MRD in AML patient. This is the meta-analysis including 81 publication, more than 11,000 patients, showing the overall survival 5 years, 68% for MRD negative patient compared with the 34% only in MRD positive post-induction. Since 2017 until today, over the last 8 years, we have almost 15 approval for new therapy for AML, including target therapy, BCL2 inhibitors, different type of FLT3 inhibitors, IDH1, IDH2 inhibitors, GO, and also the oral hypomethylating agent. And finally, in 24 and 25, we have the menin inhibitors. We have 2 agents now, revumenib and ziftomenib. NPM1 always associated with good prognosis at diagnosis, but if it's the patient relapse, doesn't matter and have no impact. If you see the left side of the slide, the overall survival doesn't matter at time of relapse if the patient have NPM1 mutation or not. On the right side, venetoclax have good activity against NPM1 mutation in relapse refractory AML with around overall survival in 12 months, 59%. KMT2, it's around 5 to 10% in AML patient, always associated with poor outcome, especially in relapse, with the overall survival at 5 years less than 25%. Also, the incidence of relapse in the first line for the patient with the KMT2A, it's around 66% in 5 years, with the overall survival less than 20% at 5 years. This is the NCCN recommendation for the genetic and genomic mutational testing in AML patient. At baseline, patient should have the karyotype, FISH, and NGS panel, and should be repeated in each relapse or progression, and should be done before the starting of the treatment. KMT2, it's linked always to adverse prognosis as ALN risk stratification. Co-mutation with KRAS and TP53, it's worsening the outcome. Mutation analysis, as you know, it's help us to decide for treatment intensity and eligibility for target therapy and transplant decision. AML, it's not a static condition. Each time of relapse or progression, we have different mutation and different driver mutation. KMT2 should be done by cytogenetics or FISH. NPM1 can be done by BCR or NGS. From the reported in menin inhibitor studies, high incidence of KMT2 in therapy-related AML. Prior venetoclax and FLT3 inhibitors have low CR rate in revumenib trial. Also, the co-mutation with IDH1, IDH2 showing improve the CR in the revumenib monotherapy in the relapsed refractory AML patient. This is algorithm suggested by Dana-Farber group for treatment of AML in 25 for patient with less than 60 years. We have core binding factor in NPM1, intensive chemotherapy plus GO, as multiple studies showing the overall survival improved with the addition of GO for core binding factor. For FLT3, upfront we have 2 approval for midostaurin and quizartinib, improving the CR and overall survival. Patients without target therapy usually go for intensive chemotherapy. Therapy-related AML going with the CBX-351 or intensive chemotherapy. TP53, it's suggested to have hypomethylating agent plus minus venetoclax, which came from the trial of aza-venetoclax, showing the subgroup analysis for TP53 patient have improved the CR rate with using the venetoclax. After the induction, we'll have morphological assessment and MRD assessment. If the patient have still MRD, suggest to have hypomethylating agent plus the venetoclax. If the patient achieve remission, can proceed for the consolidation based on the ALN risk stratification, either to have chemotherapy or bone marrow transplant. Patient from 60 to 75, almost the same with more hypomethylating agent and venetoclax, but still we have the core binding factor and FLT3 have the same as fit patient. Patient more than 75, we have, if they have IDH1, it's approved to use IDH1 inhibitors. IDH2 is still using hypomethylating and venetoclax. And the decision for the consolidation depend on the virility of the patient and eligibility to have the consolidation therapy. For relapse refractory, which is have nowadays the addition of KMT2A as a category to use the revumenib. Also, the NPM1 now approved to have ziftomenib and revumenib as relapse refractory. The same IDH1, IDH2, if they have at relapse refractory, have the same IDH1, IDH2 inhibitors. FLT3, we have gilteritinib, it's approved for relapse refractory FLT3 mutation. Now we'll talk about the menin inhibitors in AML therapy. As you know, KMT2 and NPM1, when they combined with the menin as a transcriptor factor, it's transcription factor with the HOX A9 and MIS1 program, which is lead to the keep the leukemic cells have self renewal without differentiated or apoptosis. If we have menin inhibitors, we block this complex of KMT2 with proceed to the differentiation and apoptosis of leukemic cells. Almost the same, but we have the different NPM1 and KMT2 complex, and that site of the menin inhibitors when they down-regulate the HOX A9 and MIS1. This is the menin inhibitors in the pipeline. We have the first 2, revumenib and ziftomenib, already approved by FDA. The next is still under study, waiting for approval with the promising efficacy and safety. Revumenib approved now for KMT2A and NPM1 in patients with age more than 1. And ziftomenib approved for relapse refractory NPM1 AML. NCCN guideline now incorporate all the target therapy, including the menin inhibitors. as showing in this slide with the last update 2026, with the rifampicin and ziftomenib now approved for relapse refractory. Menin inhibitors as a monotherapy for relapse refractory. This trial, Augment Trial 101, it's having relapse refractory monotherapy rifampicin. The cohort of KMT2A having patient with AML, ALL, relapse refractory, untreated relapse with the median number of previous regimen is 2 regimen with the prior transplant around 44%. This is the overall response rate around 67% with the MRD negativity 64%, and 19 patients proceeded to transplant. This is the side effect for the cohort of KMT2A, mainly QT prolongation in 29% and differentiation syndrome in 28% with all grades. If we have the NPM1 cohort showing the overall response rate 47% with the median overall survival 4 months. If we have subgroup analysis for the NPM1 in rifampicin trial, we have the response based on the prior venetoclax exposure, 19%, with prior FLT3 inhibitors, 13%, with higher response with IDH1, IDH2 exposure before. And also prior transplant have 28 response rate. Also, we have the co-mutation. Rifampicin have activity against all the co-mutation, including the RAS mutation. The second menin inhibitors is ziftomenib as a monotherapy in COMET-001 trial. It's having relapse refractory AML. It's having the CR and CRh around 23%, and median overall survival 6.1 months, and have MRD negativity around 63%. The same overall survival, but in the responder patient with NPM1 in ziftomenib trial, showing the overall survival of 16 months compared with the all the patient 6.1 months. The same, all the co-mutation have effect and efficacy with the ziftomenib trial. Also, the having showing prior venetoclax showing response in 14% for ziftomenib. Regarding the safety profile, differentiation syndrome around 24% in all grade, with no significant or clinical significant QT prolongation with the ziftomenib as a monotherapy. This is based on the initial waves of the innovation, have the 2 approval for rifampicin and ziftomenib. It's active in pre-treated, heavy-treated KMT2 NPM1 population. As a single agent, we have overall response rate around 47%, CR, CRh 20 to 30%. Also in KMT2, around 67% overall response rate. MRD negativity ranging from 60 to 64%, with the patient have proceeded to stem cell transplant if they achieve remission. Combination strategy for the menin inhibitors, it's increasing, assessing the combination with the trial, especially with the approval rifampicin, ziftomenib. Also the non-approval, the bluxeminib. It's combined with the other target therapy like BCL2 inhibitors. It's combined with our intensive chemotherapy induction, and also the new menin inhibitors, enzalutamide, which is the last one now in the still in the process for clinical trial to prove the efficacy. Encouraging if this is the safe trial, which is combination, have all oral medication, oral decitabine, venetoclax, rifampicin. Overall response rate in relapse refractory, it's 41%. Also, they tested in newly diagnosed AML with 86% overall response rate. MRD negativity, it's 93% in relapse refractory and 86% in newly diagnosed. Also, the Beat AML, which is combined rifampicin with azafin in older patient, either newly diagnosed with overall response rate around 88%, Even the patient achieve remission and have no refractory after 1 to 2 cycle. 84 of the patient achieve remission after the first therapy. This is the overall survival. The median follow-up is 6.9 in azafin-rifampicin combination, with 1 year overall survival 63%. If we subgroup to KMT2, it's 83 as overall survival for 1 year, and MBM1 for 55 overall survival. Also, combination of ziftomenib with venetoclax azacitidine in relapsed refractory and newly diagnosed AML. 83 patients in relapsed refractory and 40 patients in newly diagnosed, with overall survival 65% in relapsed refractory and 89% in newly diagnosed AML. This is bluxeminib, which is part of the combination but still not approved, have good overall survival in relapsed refractory and newly diagnosed. In relapsed refractory, it's around 81% and newly diagnosed in 90% overall response rate. Also, if we have the newly diagnosed with a dose of 100 for bluxeminib, if we see the newly diagnosed having overall response 75, all of them having CR, but was a small number of patients, only 40 patients in this cohort of newly diagnosed AML. This is also combination, which is combined of doublet, bluxeminib plus venetoclax in relapsed refractory KMT2 and MBM1 AML patient, showing promising efficacy with overall response rate 69% and composite CR is 38%. Also ongoing combination with other induction chemotherapy, which showing early efficacy of refampicin in our intensive chemotherapy for induction newly diagnosed AML, but still immature data to have judgment about the safety and especially the toxicity. Also, combination of ziftomenib with induction newly diagnosed AML patient, either to have MBM1 or KMT2. This is the dose escalation for ziftomenib. Also, the overall median follow-up is 24 weeks, with the median duration of response not reached, median overall survival also not reached. The last one in the menin inhibitors, enzaminib, which is have showing activity in relapsed refractory setting with patient with KMT2 or MBM1. Still waiting for the final result and updated data. Overall response initially it's 73%. Regarding the menin inhibitors combined with the chemotherapy for patient, it's reporting high response rate, especially with FIN-AZA. Still unanswered question about the correct combination, dosing strategy, safety profile. Menin inhibitor can be safely added to our induction or intensive chemotherapy, but the combination it's better or more intensive chemotherapy it's better, still we don't know. Also, the menin inhibitors, especially bluxeminib and enzaminib, proving more safer or low profile of toxicity compared with the previous two, but still waiting for the mature data, even the durability of the response. Regarding the safety of menin inhibitors, mainly the class effect for menin, it's differentiation syndrome across all the menin inhibitors, but with different grade, but around 15% all over the menin inhibitors. QT prolongation, especially with the refampicin. Half-life for refampicin, it's 6.4 hours, which sometimes help us to hold the medication if we have toxicity. If you see the ziftomenib half-life, it's 93 hours, but the last one, enzaminib, which is short half-life, 2 to 4 hours, which is having a limited toxicity due to early washout for the medication. Also, the ziftomenib have reported of pruritus as a side effect. Regarding the differentiation syndrome, As I said, it's ranging from 15 to 25. Grade 3, it's lower, less than 5, and usually it's manageable. Cytopenia, especially with the combination, mainly due to the part of the chemotherapy or venetoclax. Febrile neutropenia, also the same. It's mainly due to the combination chemotherapy. QT prolongation, it's always manageable, but should assess for drug-drug interaction and especially the antifungal and antiemetic, and correct the electrolyte disturbance to avoid it. GI toxicity, usually it's rare, but it's low grade. Mortality less than 3% for all, especially with intensive chemotherapy. Pattern of menin inhibitor safety experience. As I mentioned, the differentiation syndrome is class effect all over the menin inhibitors. QT, it's manageable. Pruritus specific reported to ziftomenib. Combination insights, it's ongoing assessment to additive toxicity, especially with the myelosuppression with the chemotherapy. And cytopenia mainly in induction or intensive chemotherapy related to our 7+3 or venetoclax. Potential challenge with increased risk of infection and cytopenia, especially with ongoing therapy in relapse refractory if we choose to continue on the menin inhibitors. This is just a principle how to do the baseline, normalize the WBC by cytoreductive or hydroxyurea to decrease risk of differentiation syndrome. We need baseline ECG to measure the QT interval, correct the electrolytes, drug-drug interaction. In early monitoring, in the initial 3 weeks, should have weight and renal function for the patient, frequent CBC and metabolic panel. But if the patient have worsening or new hypoxia, rapid weight gain, or sudden increase in WBC, should assess for differentiation syndrome and other febrile neutropenia and chest infection immediately. Ongoing monitoring after the 3 weeks, should do monthly ECG, CBC weekly if stable count, and watch for differentiation syndrome recurrence, especially if we reintroduce the medication or taper down the steroid. Just finally, 1 minute regarding the update of the paradigm trial, which is the azafin in young patient. This is their design of the study. They randomized 1-to-1 to receive azafin versus 7+3 or CBX35. Primary endpoint, event-free survival, and secondary endpoint, overall survival, toxicity and MRD, and hospitalization index and quality of life. This is characteristic of the patient. They include 172 patients. The median age is 64, but the range is 23 to 79. Around 70% of the patient have adverse categorization by ALN 2022. This is their response, showing the overall response favoring the azafin. Also the sub or composite CR favoring the azafin over the 7+3. But if we see the CR almost the same, no difference or no significant difference between the azafin and 7+3. Regarding the event-free survival, it's showing 14.6 versus 6.1 month, and 1 year event-free survival 53% versus 63% for intensive chemotherapy. Transplant, around 34 patients went for transplant intensive chemotherapy compared with more patients, 52 patients in azafin arm. And thank you.